Hello, good afternoon. I am going to go ahead and get started and welcome you guys. I am Rebecca Quinn. I am the director of the North Dakota Brain Injury Network. And today I'm going to be talking about brain injury and substance use disorder and just the overlap between brain injury and substance use disorder and the incidence amongst of brain injury and substance use disorder, and then some of the available resources that we have and would like to direct you to, and potentially how to modify treatment for a substance use disorder treatment for individuals with brain injury. So again, welcome. So starting out, there is an incredible amount of overlap between substance use disorder and brain injury. Studies show again and again and again that it is. And one of the things is definitely substance use as a risk factor for sustaining a brain injury. So, these results show that risk factor in adolescents and adults, 20% of those hospitalized were intoxicated at the time of the injury. 30% of those requiring rehab were intoxicated at the time of the injury. So that even shows that those that were intoxicated at the time tend to sustain a higher level of brain injury because they're the ones that were having to then have that rehab. 50% of those treated in acute rehab had a prior history of alcohol abuse. 35% of those treated in acute rehab had a prior history of substance use. And 60% of those treated in inpatient rehab had a history of substance use disorder. So a high percentage of substance use and abuse amongst those sustaining brain injury and receiving rehabilitation treatment. So I think definitely when working with individuals with brain injury, important to have that understanding of substance use disorder and understanding that a large percentage of the individuals that are sustaining brain injuries and entering rehab have a history. And then brain injury as a risk factor for developing a substance use disorder. So this is kind of looking at the brain injury as a risk factor for that substance use disorder. So 10 to 20% of people with a traumatic brain injury will develop a new onset of substance use disorder after their injury. So when previously we were looking at those that they had an already existing substance use disorder and then sustained that brain injury, now this is talking about development of a new substance use disorder after having sustained a brain injury. Another study found that 44 to 66% of TBI survivors reported alcohol abuse issues. And that study compared versus 24% of non-TBI survivors. So this was just looking at amongst the general population, the TBI survivors reported higher issues of alcohol abuse issues compared to non-TBI survivors. Next is similar kind of study was 21 to 37% of TBI survivors reported the use of illegal drugs compared to only 15% of the non-TBI survivors in that population. So this shows that there's a higher percentage than non-TBI survivors of alcohol abuse and of use of illegal drugs. And then another study looked at people with an early childhood TBI that resulted in at least one night in the hospital were found to be 3 times more likely as young adults to have an alcohol or drug dependency. The researcher that did the research around this, he really said that there was such a high correlation to that development of an alcohol or drug dependency in young adulthood amongst those that had an early TBI, that he really equated it to having to warn Little Red Riding Hood about the wolf. He really felt that we didn't spend enough time educating, parents of TBI survivors about that potential of development of a young adulthood alcohol or drug dependency. So definitely brain injury as a risk factor for that development of substance use disorder. And so part of it, again, connecting the dots, again, researchers say that, of the individuals that are engaged in treatment and those living with TBI, they tend to have first used alcohol at a younger age, have a more severe substance misuse history, have co-occurring mental health problems, and have a prior prognosis for have a poor prognosis for successful treatment. So, and the more so at the earlier age of the first TBI. So really, one of the things with this, that's why when we do screening for brain injury, we really ask about the younger age, the youngest age of the brain injury, because really a lot of this research shows that the younger that a brain injury is sustained, the more likelihood there is going to be that poor prognosis for treatment, and that individuals are going to have, first use alcohol at a younger age, have those more co-occurring issues. So important to look at that. So, and then additionally, looking specifically at opioids, one of the concerns around opioids is that people with brain injuries are more likely to be prescribed opioids. They found that 70 to 80% of people with brain injuries are prescribed an opioid during their inpatient rehabilitation. So a lot of this has to do with things related to, chronic pain with brain injury, a lot of orthopedic injuries that go along with brain injuries. So a lot of, legitimate pain prescribing happening for individuals with brain injury, but that then creating that risk of addiction and that risk of misuse. So people who have moderate to severe injuries are 11 times more likely to die from an overdose than those who don't. So I'm going to kind of repeat that because that's really a big deal. People who have moderate to severe injuries are 11 times more likely to die from an overdose than individuals that don't have a history of brain injury. So really it's important in that piece of when prescribing opioids. It's why concerning that, 70 to 80% of people with brain injuries being described opioids during their treatment, and then having the individuals with brain injury are 11 times more likely to die from an overdose. And then as a result from all of this, people with brain injuries are much higher risk for opioid misuse and overdose. And one of the concerns about this and why we specifically talk about opioids is because of that risk of overdose. Opioid overdose can be an anoxia injury, so a secondary injury. That being that acquired brain injury from the oxygen deprivation when the individual kind of has that overdose, depending on, if it's a naloxone, which is like the, opioid anesthetic that kind of prevents the overdose, stops it from happening. During that time, an individual may have oxygen deprivation to the brain, and that causing an additional injury and on top of their already sustained traumatic brain injury. And then, so that concern around opioids and that overdose. Oops. So one of the things in talking about particularly why there's such a high overlap between sustaining a brain injury and having a brain injury and then substance use disorder, and how that ability to seek treatment for substance use disorder with a brain injury. A lot of it has to do with our skull anatomy and the symptomology of brain injury. One thing within the skull anatomy of just kind of showing this is that the inside of our skulls unfortunately are not smooth. They're not a real smooth surface on the inside. Instead, the inside of our skull, as you can kind of see here, has these bony ridges. It's kind of bumpy and has ridges on the inside. And unfortunately, these ridges can result in injuries to our temporal and frontal lobe. Really, our temporal and frontal lobes sit inside of the skull. When I do this presentation in person, I actually have a skull that kind of shows how the brain fits inside and where those bumps are. It fits in there, and then when the injury happens, it causes injury to the frontal and temporal lobes. Unfortunately, the way our brain is designed and our skull, it really protects some of the important parts of our brain, like the parts that keep our heart beating, us breathing, all of that is really protected. But unfortunately, it means that like our temporal and frontal lobes are exposed and more likely to be damaged from this rapid acceleration. One of the problems with this is the impact of that. Damage to those frontal and temporal lobes, really, those are so important things related to concentration, memory, planning, problem solving, communication, things related to impulse control, inhibition, self-awareness, and really all of those skill sets are such important building blocks for an individual in independent living, but also really important building blocks in recovery from substance use disorder. That, impulse control, emotional inhibition, all of those things are really necessary as part of recovery and really being successful in any type of like recovery treatment. So again, this impact of symptomology that can be really difficult as far as accessing recovery treatment is that this may mean that individuals miss appointments, they may have trouble learning new information that's given in the treatment. They may have difficulty following any type of treatment program, routine, rules. They may have difficult for these. And what can really happen is that individuals kind of engage, being able to engage in treatment and benefit from that treatment. Particularly, a lot of substance use disorder treatment is set up to be cumulative. And, you hear of like 28-day programs, 6-week programs, outpatient, and they really expect for individuals to be able to retain information from session to session and build on that information. And that can be a real struggle for an individual that has a lot of these symptomologies. So not only is it individuals, their symptomology leads to them being more at risk for addiction because of things like impulse control and decision making and that, but then also really impairs their ability to engage and benefit from treatment. And often as providers or family members or others, they often misinterpret this symptomology. They may see this as lack of motivation for treatment. I've heard things related to having to do tough love with somebody. Well, it's really tough when, you want to do tough love with somebody in order for them to make good decisions if that individual has impaired decision-making ability and they lack impulse control. Well, then they're not making good decisions. They're just acting impulsively and acting as somebody without decision-making capacity. So really needing to look at what is that individual's abilities within that treatment. And one of the other difficulties is particularly for individuals. One of the things that we see a lot of within treatment programming is the lack of awareness of brain injury. Particularly earlier, I had talked about that impact of childhood injuries. So for an individual that, let's say, is 24 in treatment, that individual may not even remember or think about the importance of a fall off the slide when they were 6 years old. And so, but that fall off the slide when they were 6 years old may be affecting their cognitive communication, their abilities, they're having their symptomologies, but they themselves aren't even aware of that. And so being aware of those consequences can really increase that frustration on that individual part, really lead them to seeing that they're not able to access services, they don't have the cognitive ability, see themselves as stupid, this is dumb, I'm going to drop out of treatment, I'm not worth it. And so that symptomology can kind of have that impact across the board. And one of the things that we've seen is that the additive impact, as we've talked about this, there is that brain injury piece, and you have that, impact from the substance misuse. So one of the things that is well known within the substance, use and abuse, communities is the impact of using substances, whether it be alcohol or illicit substances, on an individual's brain. So that has that impact. And then when you add in having a traumatic brain injury or an acquired brain injury, they have this additive impact. And so the co-occurrence of the impairment is even more so. So an individual may have cognitive impairment from their brain injury, but then also if they're having, an alcohol use problem and, our substance use, then that is having that additive impact of the cognitive impacts from that substance as well. And then one of the things that we also know is that substance misuse also limits the outcome from a brain injury, because it is very difficult for accessing brain injury services, rehabilitation services, if an individual has a substance use disorder. So there are not many rehabilitation programs that are set up to manage substance use disorder, and many rehabilitation programs will not take an individual if they're actively using or have a history of substance use disorder. So that can really be a limit for those individuals accessing services. So, and part of that being a challenge of finding treatment. One is, again, that lack of access to specialized programs. There are not many specialized programs that treat substance use disorder and brain injury. That can be a big piece. And then even finding those specialized programs, but even finding programs that have more of an awareness of brain injury and are maybe brain injury supportive, but then on the flip side, finding if it's brain injury rehabilitation, finding brain injury rehabilitation that it has an understanding of substance use disorder and is able to provide that. So really kind of that lack of access to specialized programming. Another problem and challenge with finding treatment is the challenge of redefining new self. So for a lot of individuals, they are struggling with how to define themselves, particularly those individuals that were kind of unaware of their history of brain injury. This is something that, when I have done screening as part of like addiction treatment mall down in Fargo at Southeast Human Services, or with other providers, there really is that challenge of when you're doing screenings for individuals with brain injury, if you identify somebody as having a history of brain injury, that individual is really having to now come to terms with that, come to terms with having a brain injury. What does that mean? And particularly, how does that fit within their identity as maybe somebody that has a substance use disorder and within that population? So really having to come to terms with that. I had a group that I'd worked with in Fargo for a while that they called themselves the trifecta of awesomeness, because they were a group that they had the trifecta of substance use disorder, serious mental illness, and a brain injury diagnosis. But for many of them, that was really hard for them to come to terms that they were now carrying 3 different diagnoses that were very different, and how did they all fit together? Out of that group, I did develop a kind of FAQ sheet on what it means, what brain injury screening means, and kind of what it means to get that brain injury diagnosis. So we do have that, because I found that there wasn't something that really helped explain brain injury to somebody that was new to it and had been newly screened for brain injury. And then the final piece is part of these individuals' challenges of finding treatment. It's hard to know where to find support. For individuals that are, whether they have the trifecta of awesomeness or just the 2, whether it be like substance use disorder and brain injury, those co-occurring, should they be finding support within the brain injury community? Is that where they identify? Is that where they can be getting their support? Or should they be getting support more in the recovery community? And do they fit more in the recovery community? And a lot of times these are individuals that they feel like they're not quite sure which one they fit in. They, really could fit in either or, and they're not really sure which one exactly meets their needs. Which one kind of has that, that piece, like, where would I fit? And they feel like they're kind of Not a good fit for either. So this quadrant is kind of more explaining what I was just talking about. This is a 4-quadrant model for substance use disorder treatment and acquired brain injury treatment. This 4-quadrant model was developed by Dr. Corrigan at University of Ohio. And really a big piece of this is how to help individuals access their services, the most appropriate services they can. For us here in North Dakota, we do not have anything that fits in quadrant 4, which would be fully integrated substance use disorder and brain injury treatment. So quadrant 4, which is this light blue up here, that is that fully integrated dual programming. The closest programming we would have to this would be Vinland. Vinland down in the cities is a treatment program that specializes in treating those with cognitive disabilities and brain injury. They're wonderful. However, they do not accept Medicaid. So that is kind of a barrier with them. There are a couple other programs that we have been more successful in getting some Medicaid treatment for, but not many of them. There may be only like 3 or 4 in the whole country. So that is a tough. One time my daughter really tasked me with putting unicorns in my presentation. And so I did a picture of a unicorn with the idea that quadrant 4 really is that unicorn treatment. Not very common, not what we're really going to see or have access to for our clients. So then instead we have the 2 green quadrants. So quadrant 3 over here, the quadrant 3 is for individuals that have a high severity of substance use disorder. So this might be individuals that are actively, have an active opioid use, active methamphetamine use, severe alcoholism. This is individuals that have that high substance use disorder and are needing to access substance use treatment. For those individuals, it would be best for them to access substance use treatment that then has an awareness and supports around brain injury. And that's kind of the group that we're talking about today. How do we make sure that that substance use programming is receptive and most effective for those individuals with brain injury? Then the other green quadrant is quadrant 2. That's for individuals that are having a high severity of brain injury, but a low severity of substance use disorder. So this may be individuals that, have some significant impacts from their brain injury. They may still have quite a bit of, cognitive and communication barriers, that piece, and they would benefit from brain injury treatment. So they may benefit from an inpatient rehab program, outpatient cognitive therapy, those pieces. And within that, they're going to benefit from those providers being more aware of their low severity of substance use. So this might be somebody that hasn't developed a substance use disorder yet, but it still falls in that like substance misuse category. So an example might be somebody that, is really struggling with sleep after their brain injury. And so as a result, they have started drinking more and more in order to, be able to sleep better. So as part of the brain injury rehabilitation, it might be, okay, let's get you, let's, work on prescribing some appropriate sleep medication, sleep management, so that you can have better control of that versus the drinking. Similarly, it might be somebody that's really struggling with, I one time had an individual tell me that he wasn't a drunk. It was just that drunks were the only ones that he could socially engage with after his brain injury, because of his brain injury, he had poor memory, slurred speech, unsteady balance, and, repeated himself a lot. And he said, drunks do that. So drunks don't care that I do that. And everybody just assumes I'm drunk because I do that. So it's just easier for me to hang out at the bar and drink because that's where I can get social engagement. So in that situation, he was somebody that really benefited from a referral to, cognitive therapy and speech therapy to work with him more on his social engagement, work with him more on his ability to improve his speech and social communication, so that it was easier for him to engage outside of the bar and outside of drinking. So that's an example of quadrant 2 and where that fits in. And then quadrant one is kind of our blue quadrant. This is for individuals that are having a low severity of both substance use disorder and acquired brain injury. This again is just those that maybe this might be within like a primary care setting or working with their provider. This might be somebody that's just kind of having low symptomology for their brain injury, but would benefit from a referral to speech therapy to help work on like their social communication. But as part of that, also maybe a referral to some, low interventions to address kind of their substance misuse to really make sure that it doesn't go into more of a problem. So that's kind of the 4-quadrant model of services. Did that kind of make sense to people? I will say that for us, again, in North Dakota, the light blue category, we do not have really any of that programming here in North Dakota. So one of our goals as the Brain Injury Network is part of even doing this presentation. We really want to make sure that the 2 green quadrants are really much more aware of brain injury and the overlap between brain injury and substance use disorder, and that there are individuals with both within programming. So all of our substance use disorder programming within our state has individuals with brain injury in it. We statistically know that. We statistically know that at least 50% of their individuals have that history. And so how do we make sure that that substance use disorder treatment is readily accessible for them? And then same thing with brain injury rehabilitation. What the research shows us is that individuals accessing inpatient brain injury rehab have a history, have that potential history, and really want to make sure that brain injury rehab is asking the questions and is aware of the impact of that potential disorder. So part of that is this kind of brain injury framework for support that we at the Brain Injury Network are really trying to provide as much as we can for individuals as they access services. So one, not treating the brain injury as separate. Really recognizing that, again, the access to that quadrant 4 unicorn programming is not as readily available as people think it is. And as part of that, individuals with brain injury are within existing support services, and those individuals should be getting services where they're at within the context of brain injury. Wanting to demystify brain injury for non-brain injury professionals. Brain injury is just like any other co-occurring condition, wanting to make sure that individuals are able to access the services that they need with the appropriate accommodations and support for that brain injury. Really wanting to make sure that it's not a scary thing. Brain injury is something that we can provide the resources to help support that individual. And then a big piece of our work, particularly the Brain Injury Network, is empowering individuals with brain injury to advocate for themselves, to advocate for the services they need, and to really understand how they fit within those services in order to get the most benefit from them. So some of the factors that contribute to good substance use treatment outcome. This is particularly, some of these factors that can really help make sure that an individual has good outcome from treatment. One, and this is true of kind of across the board, whether somebody has a brain injury or not, accepting and understanding that substance use is a problem. This is a big component for an individual to be successful in treatment. Is individuals have to see that what they're wanting to change needs to be changed. They have to have that understanding and acceptance. How much an individual believes that they can change and that treatment helps. Again, earlier I said, that part of that helping educate individuals on their brain injury. Individuals, if they don't know that they have a brain injury, I've worked with a lot of individuals that had undiagnosed, unknown brain injury before that. And really, once they get that understanding and say they have light bulb moments of, oh, there's something that explains this. I'm not just stupid, or I can, I can access treatment. I can do this. It really can be very empowering for those individuals, and that being an important part of that good treatment outcome. And so that's why really important to be doing that screening and really looking at the symptoms of an individual in order to help with that empowerment so that they really believe that they can change. The level of support for a drug-free life, family and friends, how much those individuals have that support from their community. And then really, really important for family and friends to understand the risk factors for substance use in the brain injury survivor. So as I said earlier, I talked about that, the potential for substance use after a brain injury kind of being like warning Little Red Riding Hood about the wolf. Really wanting to make sure that friends and family are aware of that and have that on their radar as something that could be a potential problem and be on the lookout for. I think that's really important, particularly here in North Dakota. Our culture around drinking, our culture around substance use, sometimes really important for family and friends to have that understanding that individuals with brain injury may not, have that same ability to regulate things. It may not have that same ability. So yes, throughout, everybody in our family has always been drinkers and they've always done an okay job regulating that. Okay, but that doesn't mean that, the brother with brain injury is going to be able to continue to do that. And so making sure that there's that understanding. Another thing that's really important for good treatment outcomes is being connected and having genuine therapeutic relationships. Really, really important, how that genuine therapeutic relationship. I think that's why it's important when we talk with rehab providers and substance use disorder treatment providers, that understanding of brain injury and how that brain injury might be impacting that individual can be so important as part of that, development of that genuine therapeutic relationship and being able to have that connection with an individual. So some of the considerations for SUD treatment, often for individuals with brain injury, some of the things we know is there is a need for increased frequency of treatment. So an example of that, if, typical treatment is an individual doing outpatient treatment over, 8 weeks, it might be that they, rather than see once a week, they need to come twice a week. Or if it's typically twice a week, they might need to come 4 times a week. So increasing that frequency of treatment. But as part of that, shorter length of treatment sessions. So when I say, a typical outpatient treatment, they go twice a week for, treatment with their addiction counselor for an hour. For an individual with brain injury, they might need to go four times a week for 30 minutes. Because it's that shorter length of information that can be digested, that ability to really focus in, zone in, and have that individual be able to digest that service and be that part of that repetition of what's being talked about and what's being said. Longer duration of treatment. So this is one thing that has been shown in studies that have done, is that longer duration of treatment. So if typically an individual might be doing outpatient treatment for, let's say, 8 weeks, for an individual with brain injury, they may need it to be for 16 weeks. That longer duration to allow for more, absorbing of the information, that repetition, that really kind of continuing to reinforce the concepts, needing that. So for individuals with brain injury, they need increased frequency, shorter length, and longer duration. So those are really important pieces. And then as part of that, redefining success. I think within the SUD treatment community right now, there is a lot of redefining success, particularly around concepts around harm reduction. So harm reduction being like, we're not black and white sobriety. Instead, we're focused on how do we reduce the harm of the substances. So like within a harm reduction model, I even had one time an individual with brain injury who told me that he wasn't able to completely give up drinking, but he had given up using hard alcohol and was now only drinking beer. Harm reduction around, somebody may have given up the use of IV, intravenous, illicit drugs, but they may still be using alcohol. So redefining success and understanding that every step towards that is a success. It is a win, even if it's not kind of that big win. And so with individuals with brain injury that need to kind of redefine success and really look at what does it mean for them. And then the question of, I brought this up earlier, is tough love an option when there is an individual with brain injury and substance use disorder? This is something that I really struggle with, just ethically. And how much of an independent capacity do individuals with brain injury have? Sometimes particularly individuals that have things like impaired decision making, impulse control, difficulties with those pieces. How much are you able to hold them accountable, and how do you set up programming that is holding them accountable and explaining their behavior but not excusing it? And so that definitely is a conversation to have, and really explore further with that individual within their cognitive capabilities to make sure that individuals, brain injury, as I always say, it's an explanation, not an excuse. So we're not wanting to excuse individuals' behavior and say, oh, it's okay, they can use all they want, they can, it's okay for them to steal from their parents to pay for drugs. And I'm not saying any of that, but really looking at what is that individual's capacity for independent decision making, and how do we set up a structure that's supportive of that allows for them to get what they need without having to turn to kind of the substance use that they are. So modifying treatment goals. I think this is really important for an individual that's accessing treatment. And if you are like an addiction counselor or case manager or somebody that's working with an individual that need to modify those treatment goals. So how do we modify treatment goals in order to make sure that that individual is getting the best that they can from the treatment they are? Some of the things that are important is really just looking at how do we possibly kind of refocus or add additional goals? Wanting to make sure that goals are as structured and concrete and repetitive as possible. For individuals with brain injury, really the more simplified it can be, the better. That really structured and concrete. And I think it's really important when working with individuals with brain injury within any SUD treatment to make sure to encourage specific goals related to managing their symptomologies and to build their brain injury awareness. This is something that a lot of the individuals that we work with, we might encourage them to have goals around like attending some of our programming, whether it be attending some support groups that we offer. We lately have been offering a course called Living Life Fully After Brain Injury. Living Life Fully After Brain Injury. Right now we just finished a virtual one and are doing about halfway through some in-person ones in Fargo. But some of the pieces of that we'll be offering another virtual one that is actually taught, co-taught by a peer support specialist that has lived experience with brain injury and is in recovery himself. So that would be a good one to, have a goal around an individual attending a Living Life Fully class and completing that, or like I said, attending our support group. In a little bit, I'm going to talk about our tip cards and that sheet. I saw in the chat, somebody asked about our screening piece. So some of those tip sheets, it may be a specific goal around, adapting some accommodations recommended in our tip sheet. So making sure that their treatment goals are not just built around their SUD treatment, but also helping build in their understanding further of their brain injury and how that injury is affecting them. And then also building in some things to help modify behavior as needed, recognizing that some of these behavioral pieces may be related to the brain injury and may need structured modified intervention. So like teaching de-escalation techniques, understanding that for that individual, they may not know how to do that. They may not have ever had an understanding of their kind of emotional regulation and de-escalation after their brain injury. And so wanting to work on treating those, teaching, how to better de-escalate. I had an individual once who had substance use disorder and really struggled with anger management and his kind of escalation, which was really a struggle as far as it was impacting his treatment and part of his brain injury. And really worked with him on just even helping him understand how he processed information. With that individual, worked with teaching him de-escalation techniques of learning to even think about like his ability to like tolerate and his tolerance bucket, and that most people might have a 5-gallon bucket of tolerance that they're able to fill up with, but he only got a little bowl, and he's kind of got this little bowl, and so his bucket fills that much quicker and he needs to empty it more. What are the ways he can empty it? And we also kind of compared it to, some people have a slow cooker, but he has, a pressure cooker, and, he gets riled up much quicker. And how does he empty that? And how does he work on that? So kind of really even teaching some of those techniques. Similar to teaching boundary setting. With boundary setting, this might be for particularly a lot of individuals in treatment. I've worked with a lot of individuals with brain injury that really struggle with that socialization as part of that boundary setting. They oftentimes don't know how to say no to people. They don't know how to set boundaries. They're not capable of kind of doing that. And so need to have some training around appropriate socialization and appropriate boundary setting. So support during treatment groups. I think this is really a big piece of any type of substance use disorder treatment. A lot of it hinges on treatment groups. Treatment groups are such a key piece of substance use disorder treatment. However, one of the things that we know is that individuals with brain injury really struggle with any type of group therapy. Groups can be very overwhelming for individuals with brain injury, really difficult to digest information, the knowledge, all of that. So it can really be a huge struggle. So important to look at how do you support these individuals for these treatment groups. And if you are doing treatment groups, be on the lookout for individuals that are struggling with group, because those may be your individuals with undiagnosed brain injury, those individuals that are really struggling for accessing that information, and ones to put on the kind of the radar of like, okay, hopefully you would have already done screening on everybody, but if not, saying, okay, this is somebody I probably need to screen because I see that they're really struggling in a group, and I know that can be difficult for individuals with brain injury. But some ways to support that, pairing new participants, so new individuals, with an experienced participant. So if you have individual kind of the buddy system, as I said, we have our peer support specialist that works with us and teaches our group, but you may have a peer support specialist available that can go with them. You may have an individual that can, is able to help explain it to them, really be able to be that buddy. Don't insist upon sharing our participation right off the bat. Understand that the whole process can be very overwhelming for that individual, and allowing them to have some time in group to just kind of understand the group process and to learn those social norms before you insist that they do any type of sharing and participation. And then if they do and they are ready to share information, help them, one-on-one individually during like a individual session, help them organize their thoughts ahead of time. These are really important for any time an individual with brain injury is going to be, engaging in a group, is helping with that, organizing their thoughts ahead of time. So it might be in session talking about, say at this next group, the group is going to be talking about, boundary setting with peers around, substance use. Is that something you think you would like to share? What do you think you would like to share on that? Can I help you organize that? How about we write down some thoughts that you have around that on paper? What are your kind of thoughts on that you might be able to share? So that's an important piece, that they have that. And then in providing, I think this is really important for any time individuals when it's in a group, is providing a post-group recap to help them process what was shared. Many individuals with brain injury struggle with slowed and delayed information processing. So that ability to digest the information afterwards. And so this might be something like either, if groups in the morning, then in the afternoon, or the next day, hey, at group yesterday, we were talking about setting boundaries with peers around use and peer pressure. What did you think of what was shared? And you might even call out, Sally shared some important points on that. What did you think about what Sally had to say? How does what Sally had to say apply to you? So really helping connect those dots for them. Individuals with brain injury really, really struggle with connecting those dots. And so needing that help, particularly also that applying it to them. That example that I just gave of Sally shared information at group about how she struggles with peer pressure. How does that apply to you? Individuals with brain injury really struggle with that, seeing themselves in other situations or being able to take what somebody else says and apply it to their own life. So helping them kind of make those connections through a recap process. Definitely allowing for any self-determined breaks, stretches, sitting away from the group when comfortable. Individuals with brain injury, part of it being this for supporting that individual with brain injury, but also for supporting the rest of the members of the group. If an individual with brain injury is becoming too restless, they're struggling, too much, wanting to make sure that you kind of have let them know it's okay for you to maybe stand up and not sit and instead stand during the group. It's okay for you to step outside for a minute and take a break. So that being something that you can, talk with them and work out so that they have that ability. So as part of, we just talked about groups, but now we're going to talk about accessibility of 12-step meetings. 12-step meetings can be and other kind of community support meetings can be really, really important and big components in recovery for individuals. And it has been shown, there was one, group that showed greater involvement in AA has been observed in impaired versus compared to unimpaired clients, suggesting that social support for recovery might be particularly useful for bolstering treatment. So it's saying that individuals with impaired, cognition were more likely to have greater involvement in AA. So really they saw it as a greater need for themselves. So, but wanting to make sure that it is accessible for them. One big piece is sharing any recovery materials at appropriate literacy levels. So like the big book, modified 12 steps, there are modified 12 steps out there. If you want, access to them, you can Google them. There's one, I have one that was given to me a long time ago by somebody from Finland. The 12 steps, for those of you that don't know, are the really key kind of part of AA of following these 12 steps for treatment. And many of the 12-step meetings follow these and go through the different 12 steps. But the 12 steps can be kind of vague, and they were written by highly educated men who had kind of a broad conceptual knowledge. They can be really difficult for somebody with impaired cognition to understand and follow. So really wanting to make sure that they are at kind of a clear, concrete for those individuals. So as I said, they are available out there. You can, like I said, Google modified 12 steps and there, but that's an important piece for individuals if the individuals are struggling with that. Collaborate with that individual on, again, as I said, that developing a buddy system like we talked about earlier. So making sure that they have somebody like goes to their first group with them, helps them seek out groups that may be more beneficial for them, might be more able for them to be accepted into a group. And then working with that individual on helping them understand how to introduce themselves to like other members of the group or a potential sponsor. Really wanting to make sure that they kind of like what would be their elevator speech for who they are and about their brain injury, and how that person, you know, like if they're going to have a sponsor, how that sponsor can help support their brain injury. So talking that through with them, you know, what would they like to share about their brain injury with their other members of the group, with the potential sponsor, and what are the resources they can use to help those individuals understand brain injury better. So I think that's a really important piece of it, is how to help that individual know when to share about their brain injury and how best to share it. And then really recommending any movies or TV shows that depict people attending 12 steps, so they kind of understand the process, so they have that better understanding of that group sharing process and how that works and what the benefit is. So I think that that's really important too, to kind of set them up for like, this is what a typical is, so they have kind of better understanding that can help alleviate some of that fear. Here is some information for sharing with individuals with brain injury about that use of substance use with a past brain injury. So making sure that people understand the impact that their substance use is having, not just on them as a person, but also on their brain injury recovery. These can be important pieces that can be used for like motivational interviewing with somebody, for helping individuals, you know, understand the importance of being in recovery, for them reminding them why they want to be in recovery. So people that use alcohol or drugs often don't recover as fast as those who don't. Any injury related problems related to balance, walking, talking, slurring speech, any of that can be made worse by drug or alcohol. You know, remember earlier I talked about that gentleman that said, you know, it's not that he wants to be a drunk, but those are the only people that want to be friends with him. But pointing out to him, but okay, yes, you have problems with balance and walking, but they're made worse when you're drinking. And so how do we lessen your drinking so that there's less of an impact on your symptomology? People who have brain injury often do and say things without thinking first. You know, that impulse control, and that's only going to be made worse. So, you know, helping that individual understand that they really struggle with decision making, but their decision making is going to be that much worse if they're using drugs or alcohol. Same thing with any problems with like thinking, concentration, memory. You know, if you're somebody that really struggles with memory after brain injury, drinking alcohol is only going to make that memory impairment worse and really impact your ability to adapt any accommodations. I think an important piece is that after brain injury, alcohol and other drugs have a more powerful impact. This is something that many individuals report, is that after brain injury, their tolerance is much lower, and they have much higher side effects to intoxication than they did before their injury. People who have had a brain injury are more likely to have times when they feel sad and depressed, and that drinking or using drugs can only make these problems worse. And that after brain injury, if an individual drinking alcohol or drugs can increase that risk of seizure. There is a risk for seizure after having a brain injury and a risk for seizure in use of alcohol and drugs, but the combined effect can increase that risk. And then people who drink or use other drugs after a brain injury are more likely to have another brain injury. One thing that we really try to work with our brain injury survivors is once you've sustained one brain injury, you are at heightened risk of sustaining another brain injury. And we want to lower those risks as much as we can, because brain injuries do have a cumulative impact. So the more you sustain, the more impact you're going to have. And so one of the risk factors is drinking alcohol and other drugs. So really wanting to make sure that that individual, letting them know that, because you've already had one brain injury, we want to make sure you don't have a second one. And a way of doing that is by reducing your drinking and reducing, the drugs you're consuming. So those are kind of just important talking points around that, after brain injury, substance use, and the impact it can have. So support and aftercare for after somebody's attended and gone through treatment. As I said, individuals with brain injury in any treatment setting may require post-discharge supports, particularly longer than their peers without a history of brain injury. They may require more like calls and text, more information regarding access to treatment, even, an awareness that they've gone through recovery and that they are. I even knew of an individual once that he had such a bad memory impairment that he would forget that he was in sobriety. And so they set up memory ways for him to remember that, so that he could continually remember that he'd gone through treatment and that he was sober and that piece. And so, but having that post-discharge support, these are things where I definitely would recommend for individuals with brain injury that are going through treatment or have discharged from treatment, having set up ongoing aftercare, whether it be from like a peer support specialist, a care coordinator. In the state of North Dakota, I would really, really recommend, programming like accessing like 1915I state plan amendment for that care coordination, peer support, seeing if the individual possibly applies for programming like Community Connect or Free Through Recovery, to provide some of that real ongoing recovery support for that individual once they have a discharge from recovery. And really wanting to, essential to fortify that individual's insight, make sure that individual understands the importance of their natural supports as well. The importance of family, whether it be family, friends, those pieces. What are the natural supports in place that are really going to support that individual, and making sure that those natural supports have an understanding of brain injury. Important to, be educating around what it means to be supporting an individual with brain injury. Again, really important for anybody in recovery, but particularly individuals with brain injury, avoidance of any environments that can cue relapse, wanting to make sure that the individual, is staying away from friends, family, all of that. And then the potential expanded use of medication-assisted treatment. For many individuals with brain injury, medication-assisted treatment has really been a big key to them maintaining recovery, because it really helps with some of that craving and, cutting off that part of their addiction. And so can be a key piece to utilizing that. So now I'm going to talk about some of the helpful tools that we have. I had seen in the chat that somebody had talked about, could you send out the brain injury screening form and education for the patient with brain injury? Absolutely. So that's this piece. This is our screening process and resources. So at the North Dakota Brain Injury Network, we have developed a brain injury kind of screening virtual toolkit. So that's this sheet here. It does have our kind of the whole screening process with the consent form, the screening form that's here that screens for the lifetime history of traumatic brain injury. It has all that, and then does have a data entry portal for you to capture this information and to, enter in the information. So if you have not attended one of our trainings on this screening process, we do have a lot of it out there, but you are welcome to reach out to us, send me an email, and I will kind of send you the information on the screening process and a part of that and how to access this virtual toolkit. And a piece of that, this website does, the virtual kit does have like a training on the screening process, a training on my client screen positive for brain injury. Now what? That's the one where we kind of walk through all of the various kind of, excuse me, cognitive symptoms and how to support them. And then this roundtable discussion training. This is a really great one to watch. If you are working with individuals with brain injury, particularly in recovery, at this roundtable discussion, we did this for the North Dakota peer support specialist. And so this was where we did have a group of peer support specialists with lived experience in brain injury share their experiences of being an individual within the recovery community and having a brain injury. So really a great opportunity there to kind of hear that and that understanding. So please feel free to reach out to us about this process. As part of that process, we do have the symptom inventory as part of this. The symptom inventory, so back if we go previous, is right here on number 4, the symptom inventory. So if an individual screens positive to this screening, you then can give them this symptom inventory. And this is a simple 4-page assessment of the 9 most common brain injury kind of symptomologies. This was developed by a neuropsychologist out of Colorado. So we did not develop this, we're just utilizing it. But it's 4 pages, 9 sections, and it's the most common symptomology after brain injury. So as part of, if an individual screens positive, you can have them complete the symptom inventory that will give you a general guide of where they're at cognitively, where they're at, what are the symptoms they're most struggling with. And then as part of that, the next step is that we have these tip sheets. And we have 16 of these tip sheets that are developed. So the 9 that match the symptom inventory, but then also an additional 7 that were just general things that we felt there needed to be a tip sheet for. There is, for most of them, I think almost all of them, there is a tip sheet that is specifically geared towards the participant and a tip sheet specifically geared towards you as the professional. And for all of them, they describe, so here's the attention one that you can see. It describes what attention is, the different types of attention, what to look for when an individual is struggling with attention, and then attention accommodations. So if you're working with somebody that scores high on attention on the symptom inventory, that lets you know that, one, you would then get a tip sheet to go along with that, that you can then explain to that individual. And maybe it be part of your one-on-one counseling with them or your one-on-one working with them, or even if it's a peer support specialist working with them. You know, hey, you scored high on attention. You know, these are the type of things that involve attention. Do you see that as a problem? You know, do you feel that your attention is really impacting your ability to like track in groups? And is that part of why you're having problems picking up on what's being said in group? How can we really work on that? And then maybe go through the accommodations with that, you know? Okay, so for the accommodations, you know, it recommends taking frequent brain breaks. What do you think that do you think it would help if group, rather than us doing group for a full hour and then taking a smoke break at the end, we broke group up into 30-minute segments so that you could have a break and just a little 5-minute break in the middle, you know, really helping like, and then kind of, hey, let's try that for the next month and see how that goes. So really working on how to help with those things. So again, we have 16 of these. They all are available on our website. Right now, Carly actually has been working on doing a little training recording that goes through each tip sheet to help explain it. I would say only about 1/3 of them right now have the recording with them, but soon they all will. But even if it's something that you just wanted, you know, your client or individual to access those, watch that recording, or you wanted to watch that recording yourself to help you explain it better, those are available. And if an individual, they are all available on our website here, but also if an individual completes the symptom inventory, we would custom tailor to which one of these tip sheets match how they scored on the symptom inventory and send out kind of a result sheets that shows that. Another helpful tool dealing with substance use disorder and brain injury is very recently, this came out last September. This is a Making Connections toolkit that was put out by the Mountain Plains Addiction Technology Transfer Center in partnership with NASHA, which is the National Association of State Head Injury Administrators. And for those of you that don't know, the MHTTC is are the MP-ATTC is here, run out of University of North Dakota. So this is a North Dakota product here, made as well, and in partnership, we worked with them. So Thomasina Henkamp has been a long time professor at UND. And it's a great toolkit of really how to adapt. In fact, a lot of the stuff that I talked about today is from this toolkit, but it goes into much more details about how to adapt addiction recovery and service delivery for individuals with brain injury. So it is a great resource available. And it is on our website. I didn't include the link there, sorry, but it is on our website. It also, you know, is available from the ATTC. And then another one is the SUBI client workbook. I have been a huge fan and recommended the SUBI for forever. This one is also on our website. The SUBI workbook has been around, I would say, since the late 90s. But they recently, in like 2021, updated this 2.0 client workbook. And this is a client workbook specifically developed out of Canada for individuals with substance use disorder and brain injury. And it is a much kind of slowed down and adaptive approach to working with individuals. I really encourage it. These are the table of contents for it. It really is a great resource that's available out there. So I highly recommend that. And so that is it that I had today. So I am more than happy to answer any questions or pull links for you guys for those things. So anybody have any questions?
How often do you see the brain injury coming out of domestic violence? Because that's the thing. I think that's kind of an undiagnosed oftentimes area.
I actually have a whole presentation titled The Population with More Brain Injuries Than the NFL about brain injury and domestic violence. That actually is one of the highest, I would say, kind of special populations of brain injury. Some of the populations that, you know, are kind of have much higher incidence of brain injury, and I off the top of my head, I'm going to do this, so you'll have to kind of forgive me, but roughly they say that about 40% of the homeless population has a history of brain injury, about 50 to 60% of the substance use disorder population, about 60 to 70% of the criminal justice population has history of brain injury, but estimates put the population as high as 70 to 80% of the domestic violence population have a history of brain injury. And that is one of the things, you know, our screening does ask about that history of repetitive abuse and time periods when individuals had repetitive abuse. And our screening actually also asks about choking and strangulation.
Okay. Is that a recording I could get? Could you send it out, or is there a way to find it?
Yeah, I could send that out to you, definitely. I'm trying to remember where we have it recorded, and I've done it, and it's maybe one that we should do in a webinar Wednesday on, because I know most recently I did one for CVIC here in Grand Forks presentation on it, but I'm not sure if we have a recording of that.
Okay. And is there good tools out there for the ER? Because I'm in a hospital setting, so for the ER to use to try to even, I don't know, do they routinely screen some of their patients with, you know, just, is there the basic brain injury screening? Because there's so many people that could come in with it and not know about it.
Yeah, I would say definitely not in an ER setting do I know of ones that are screened. Particularly one of the things that, you know, thinking about is that past history of brain injury versus an acute brain injury. And, you know, ERs are most likely looking at that acute injury and are not thinking about past injuries from, you know, previous and that individual having that history of brain injury. But having that history of brain injury can have such an impact on the individual's cognition and their behaviors and their ability to access services. That's why we really focus on that need to screen for that past history of brain injury anytime you're providing services to an individual, to make sure that they, you know, you're looking for any cognitive symptomology and any behavioral symptomology and you're appropriately identifying that.
Okay, because they have a lot of substance abuse cases that come through for sure. Yeah.
Yeah, definitely. And I would say it'd be great if they were screening those for history of brain injury, but I don't know that any of them are. Any other questions? No, no other questions? So I put a link in for our related services page, and if you scroll down, substance use is one of the areas, but it also does talk about criminal justice, kind of lots of other services on there. So we are currently working on a lot. Patricia's question, we are working on developing our domestic violence programming. There's actually a really, really cool programming out of Ohio that did a lot of around specifically working with domestic violence and regional shelters that were working on adapting some of their materials and working more with the homeless population. We actually have started, Fargo has a new downtown homeless engagement center. And one of our new, our Living Life Fully classes, we're kind of been partnering with that downtown engagement center in Fargo and doing some screening with them most recently. So that's an area that we're wanting to expand on. Any other questions?